We all know anemia is a very big problem, and I think over the past 30 years, the incidence and the prevalence, especially in India, has gone unchanged. With government putting in so much of efforts, we still do not know what is the reason, why is it happening. So still we have to tackle it from some other end. Probably the compliance is not there, or the patients are not following up well, because the once they get their anemia treated, they start feeling better, they go back again to the same part, again deficiency comes, and only then they will come to us. They are not realizing that their stores also have to be fulfilled, so that they do not become anemic ever. So government is now taking that line of an endeavor to see to it that everyone starting from schools, they are taken care of, so that they have adequate amount of hemoglobin and they perform well in their studies. Prevalence of anemia in pregnant women is to the tune of 50% in India. That's a lot, because an anemic woman will beget an anemic baby and the cycle will go on. So anemia is a global burden, with India falling in the limits of 40 to 59%. That is very, very high. It's a level of public health significance of severe enormity. And the worldwide anemia is around 1620 million people are living with anemia. Globally, the percentage is 41.8 to 57.4 million pregnant women, and in India, pregnant women of between 15 to 49, it is 52.2%, non-pregnant in the same age group is 57.2, and all women in the age group of 15 to 49, it is 59.1. This has come from the National Family Health Survey number 5. So the definitions of anemia, maybe whatever the guidelines are given by different authorities. WHO gives a little bit, it'll vary between 1 gram. So the CDC says less than 11 in first trimester, 10.5 in second, and again 11 in third trimester. WHO says 11, and postpartum anemia also falls nearly in the same levels. WHO says 10 and UK also says 10, FIGO says 11. But Indian guidelines are nearly the same as what we have in pregnant and non-pregnant. In mild, how to classify mild, moderate and severe? In non-pregnant women above 15 years of age, it is 11 to 11.9, that is 11 to 12. Moderate is 8 to 11, and severe is less than 8. For pregnancy, we just decrease 1 gram per deciliter from the same guidelines, and we get the figures as 10 to 11 mild, 7 to 10 would be moderate, and severe would be less than 7. So most of us women, they fall in moderate levels. Severe we do see off and on. So total iron requirements in pregnancy increase because there is a burden of increased circulation, because the baby is there. Baby circulation, placenta is being formed, another vascular organ. So body iron's requirement increase. The average daily requirement of iron has been calculated as 0.8 milligram per deciliter in first trimester, increasing to 7.5 milligram per day in the third trimester. And average daily absorption from Western and Indian diet is nearly the same, 1 to 5 milligram in Western and 0.8 to 4.5 in Indian diet. So dietary supplementation is nearly the same for the both, but probably the difference in our population is that we are lacking the iron stores. And that is the reason why more and more percentage of women become anemic during pregnancy. So total iron requirement during singleton pregnancy is 1000 to 1200 milligrams. The consequences we all know, there would be medical complications, reduced blood oxygen levels, shortness of breath, fatigue, palpitations, tachycardia, angina, hypoxia causing nausea, weight loss and abdominal pain, central hypoxia causing headache, vertigo and lethargy. And pregnancy complications are increased risk of preterm delivery, premature rupture of membranes, preeclampsia, IUD, intercurrent infections, antepartum hemorrhage, congestive heart failure. The baby is also not spared. The baby would have complications like low birth weight, prematurity, infections, congenital malformations, neonatal anemia, abnormal cognitive development, which will really reflect in the baby's future life. So maternal anemia contributes to 18% of perinatal mortality and 20% of maternal mortality in South Asian countries, including India. So that's a very big challenge. So diagnosis is again from the history and clinical examination. CBC is done, hemoglobin counts, hematocrit, MCV, RDA, a combination of low MCV and elevated. Iron deficiency anemia has low MCV and low MCH, which is same as thalassemia, but red cell distribution width is bigger in iron deficiency, because iron deficiency is represented by macrocytic and macrocytic also. So that is the differential diagnosis between thalassemia, red cell width distribution measurement. And iron supply can be gauged by serum iron calculations, TIBC, transferrin, but they are unreliable because they have diurnal variations. Iron shows diurnal variations and affected by dietary influences, pregnancy itself increasing TIBC even in the absence of IDA. Serum ferritin is supposed to be a very good marker and a cutoff of 30 micrograms per deciliter, but probably this is according to the Western indications. But over here Dr. J.B. Sharma has said that we can go up to 11 micrograms per deciliter, and above that we will feel a little bit better. So bone marrow examination is the gold standard, but it is too invasive to be done for all. And peripheral blood smear to know about the red cell width distribution. So Anemia Mukt Bharat guidelines in 2018, government gave anemia management protocol for pregnant and non-pregnant all. The first level of treatment is 2 tablets of iron folic acid, 100 milligrams iron and 500 folic acid daily for 6 months. If these are not enough, then parenteral iron can be considered as the first line management in pregnant women who are detected to be anemic late in pregnancy, or in whom compliance is likely to be low, or you feel they would be lost to follow-up. If no improvement after the first level, the improvement is judged by increase in hemoglobin level by 1 gram per deciliter after 2 weeks. So referral to a higher health facility is required, maybe because the lady might require additional investigations. The case may be managed with IV iron sucrose or ferric carboxymaltose. And when there is a severe anemia between 5 and 7 grams, immediate hospitalization. It is the 3rd trimester of the pregnancy where round the clock specialist care is available, and treatment will be done using IV iron sucrose or FCM by the medical officer, or maybe require an add-on blood transfusion because it's late in pregnancy. So indications of parenteral iron therapy would be failure of oral iron therapy, non-compliance or intolerance to oral iron, late or 2nd trimester or 3rd trimester with moderate to severe iron deficiency anemia. Rapid rectification of anemia and repletion of iron stores is expected once we give parenteral iron therapy. Malabsorption is there, then obviously nothing is being absorbed from the intestine, she needs something parenteral. Bleeding diastasis when hemorrhage is likely to continue. So this is the shortcut method of if we want to stop blood transfusion or decrease the rate of blood transfusions. Contraindications would be gestation period, that is in the 1st trimester, lack of facilities for resuscitation, known history of anaphylaxis or reactions to parenteral iron, and known state of iron overload. So IV iron is superior to oral iron in terms of speed and absolute extent of rise in hemoglobin and replenishment of iron store. It gives a lot of satisfaction to the consultant also, that at least that amount of iron has gone and it has been given by me. So she knows that her patient at least would not suffer from iron deficiency anemia. Maybe the stores might be depleted, but iron deficiency anemia would definitely not be. So evolution of parenteral therapy, it was since 1932, and now we have come to ferric carboxymaltose from 2013, which is supposed to be very safe. So an iron isomaltoside has come in 2020. So we'll see what is the best for now. Parenteral iron, the structure of iron has been going on change because parenteral iron was associated with severe adverse reactions. The reason was that elemental iron was released immediately, and that is the reason why we get severe toxicity. So rapid release of large amounts of iron, of labile free iron, leads to toxicity and adverse drug reactions. Currently available IV irons are iron carbohydrate complexes based on spheroidal particles, each consisting of a core of iron surrounded by a carbohydrate shell. So that iron molecule is not released as a free radical. Larger and more complex carbohydrate shells of newer IV irons allow controlled release of iron from the core and mitigate the release of labile free iron, which is the reason for adverse reactions. This allows administration of large doses of iron in a single dose and a short duration of time, which is very convenient for the patient as well as the consultant. So the properties are, the ideal would be it should be a robust with a molecular weight greater than 100 kilodaltons. Stability should be high, half-life should be long, pH neutral, isotonic osmolality and antigenicity should be low, and test dose should not be required, and time of injection should be short, and maximum dose we can give a high dose. And these all criteria are being met by FCM, which has a robust and 150 kilodaltons as a molecular weight with a stability high and 16 hours of half-life, near neutral pH and osmolality as isotonic. Antigenicity is low, no test dose is required. 15 minutes is required for 1000 milligrams and maximum dose is 1000 milligrams infusion, and it can be repeated if required in a week's time. So parenteral iron preparations are different types of complexes depending on the thermodynamic properties. Type 1 complex, which have a strong thermodynamically stable, this is FCM isomaltoside and ferromoxitol and iron dextran. And moderately strong are iron sucrose, which is type 2, and type 3 is a weak ferric gluconate, iron citrate and iron sorbitol. Because it is weak, it will release free iron very freely. So as per the chronology of approvals, the first generations are iron dextran, heavy molecular weight and low molecular weight, and second generation ferric gluconate and iron sucrose, and third generation we have FCM and isomaltoside. So parenteral iron, limitations of parenteral iron, like we all know that dextran was associated with severe adverse reactions, severe allergic reactions that could lead to anaphylaxis. An IM injection is painful, stains the buttocks and requires multiple injections. Low molecular weight has mitigated a little bit of these side effects associated with non-fatal serious adverse effects. Test dose is required and long IV infusion time if we need to give it IV. Over 1 hour is required. With ferric gluconate only approved for treatment of iron deficiency anemia in chronic kidney diseases, can only be administered in low dose as is associated with free high labile iron. Multiple visits would be required. Iron sucrose again can only be administered in low doses and with multiple clinical visits required. And ferromoxitol, we are not using this. Isomaltoside, it has come, but it is less better than FCM, contains highest amount of labile iron among the third generation parenteral iron. More is the labile iron, more is the risk of hypersensitivity. So advantages of FCM, it overcomes the low dose limitation of iron sucrose. Type 1, dextran free, robust iron with long half-life, stable complex, does not release non-transparent bound iron, structure similar to ferritin deposited easily in reticuloendothelial system, low antigenicity and no test dose is required. So it's a safe option at higher dose 1000 milligrams versus that is against iron sucrose, which give 200 milligrams of elemental iron of iron sucrose in single infusion. Few clinic visits are required and near neutral pH and physiological osmolality, so there would be low rate of reaction at the injection site. So comparison of iron sucrose with carboxymaltose is half-life of iron sucrose is 20 versus FCM as 7 to 12 hours. Dosage is, we can give maximum 200 milligrams and we have to repeat maybe 3 doses, 600 milligrams in a week. So the patient needs to come thrice, and over here maximum weekly dose can be 1000 milligrams. Molecular weight of FCM is 150 kilo and molecular weight of iron sucrose is 43, labile iron is 3.5%. This is where the reactions come from, and FCM has only labile of 0.6%. Test dose is always required for new patients in iron sucrose, but in FCM no test dose is required. So time for injection is 3.5 hours for 500 in iron sucrose and only 15 minutes for FCM. Maximum dose is 600 milligrams per week. Here it is 1000 milligrams, and it is, both are not to be used in first trimester of pregnancy as far as possible. So the critical attributes again are the same. It's a robust parenteral iron not associated with dextran induced hypersensitivity, can be administered in higher doses, short infusion time 15 minutes, iron is released slowly avoiding toxicity and oxidative stress, structure is similar to ferritin deposited easily in reticular endothelial cells, no test dose is required and low antigenicity. So the contraindications again is the same, first trimester, known hypersensitivity, hemochromatosis or anemia that is not due to iron deficiency, asymptomatic thalassemia minor. IV iron is not contraindicated as long as the presence of iron deficiency is confirmed by a low serum iron ferritin level, and if in doubt a specialist advice can be taken. An active systemic infection, we are not giving IV iron. So precautions would be can cause hypersensitivity reactions including anaphylactoid, which may be fatal, can occur after previous uneventful doses. So always be very careful wherever you are giving repeat doses to a patient. Cardiopulmonary resuscitation facilities are a must. Avoid in women with hepatic dysfunction where iron overload is a precipitating factor, in particular porphyria cutaneous tarda. Use with caution in acute or chronic infections. Use with caution in asthma, eczema and other atopic allergies, because they already have lots and lots of monocytes and prostaglandins, and their anaphylactoid reaction will be triggered by a very minuscule of a dose as well. So paravenous leakage may cause permanent skin staining, so this has to be avoided at all costs because we are dealing with beautiful women. So calculation of iron dose is by Ganzoni's formula. Its iron requirement in milligram, total iron deficit in milligram is equal to body weight in kilograms. For an overweight patient, we take the ideal body weight for that age, and for an underweight, we use the actual body weight. Body weight in kilograms is into target hemoglobin minus actual hemoglobin in grams per deciliter into 0.24, and we add 1000 milligrams for the storage iron. So FCM, how we are giving total iron deficit. So it's a rough calculation. When the hemoglobin is less than 9 grams, body weight 35 to 50, the total iron deficit is around 1400 milligram. So we can divide it into two doses as 700, we don't have 700 doses, it will be 750 and 750. If the weight is greater than 50 kgs, the deficit comes out to be around 1500. So 1000 first dose and 500 the second dose, or you can again divide into 750 each weekly. And body weight above 70 kgs, deficit is around 2000 milligrams. Both the doses have to be 1000 milligrams each. When the hemoglobin is above 9 gram percent, the total iron deficit is 1000 milligrams for 35 to 50 kg body weight, and both the doses can be 500 each. And in greater than 50 kgs, again it is the same 1000 milligrams, and we can give a single dose or two doses. And body weight greater than 70, it is 1500, and again it can be divided 750 each, or 1000 or 500. So setting up of the infusion, add the calculated dose to 100 ml of sodium chloride. But what I usually do is we take a bigger bottle of sodium chloride, set up the infusion, because once you add iron to that infusion and then start seeing, then you don't know the vein has been entered or not, and there will be paravenous infiltration. So set up your drip first and then put the iron dose. So if I don't have a 100 ml bottle saline available, I set up with, leak the 500 ml bottle to around 150, let the 50 ml run and then add the iron dose to it. To ensure stability of infusion, do not dilute the required dose to concentrations less than 2 milligrams per ml. It should not be over diluted, it should not be under diluted. Excess dilution destabilizes the iron complex and may cause increased adverse effects. After dilution, infuse immediately. So we have set up the drip, so the infusion is going rapidly. And a volumetric infusion pump, ideally do not use the pink cannula, always use the green. So at least that is a 20 gauge cannula, and you can finish the drip in 15 minutes. And this is the way it has been set up, that 250 ml in FCM in 750 has to be infused over 15 minutes. Adverse drug reactions are potentially related to long duration of infusion or dilution of FCM in higher volume of saline. So do not do that. Do not get into the greed that it is a 500 ml bottle, let me dilute it in 500 ml. So the possible mechanism would be long duration of administration and excess dilution may lead to destabilization of iron complex that may cause adverse reactions. So administration, flush the cannula with plain saline before infusion to confirm the patency. That's what I was saying. Infuse ICM, FCM diluted in saline over 15 minutes. Monitor injection site and educate women to immediately report any discomfort, burning, redness or swelling. In case of paravenous leakage, stop infusion immediately. Brown staining of the skin can be permanent, so be very careful how to counsel your patient. May occur due to leakage of the drug into the tissues around the injection site. On completion, again infuse 50 ml saline to ensure drug is flushed completely, and do not administer more than 1000 milligrams of FCM in a week. So monitoring is check for any pre-existing skin rashes, monitor vital signs before and after the infusion, 5 minutes after commencing the infusion and on completion of infusion. Ensure the patient does not feel faint upon mobilization, and in antenatal patient confirm the presence of FHS on admission during the infusion and after the infusion. Monitoring should be administered only when the staff is trained to evaluate and manage anaphylactic reactions, and the drugs should be available. Essentially an emergency drug tray should be there, and full resuscitation facilities have to be assured. The patient should be observed for adverse effects for at least 30 minutes following each FCM. Anaphylactoid reaction, although occurs most frequently within first few several minutes of administration, so you have to be very cautious, and in the first 3 or 4 minutes observe the patient very closely. Generally characterized by sudden onset of respiratory difficulties, tachycardia and hypotension. Stop the infusion, lie the woman flat. If the uterus is greater than 20, use a left lateral or a wedge. Oxygen at greater than 6 liters per minute, preferably 12 to 15 liters per minute via non-breathable mask has to be administered. Adrenaline, oxygen and steroid should be available if required. Response chart with frequent observations including pulse oximetry, blood pressure and respiration until symptoms have resolved. That is, we keep the woman under observation for minimum 1 hour, and do not recommence infusion or do not start it again the next week thinking she will not be having reactions this time. The side effects, the common side effects are headache, dizziness, nausea, hypertension, flushing. Hypophosphatemia seen is around 1 to 10% of the patients. Uncommon between 1 and 1000 would be fever, fatigue, peripheral edema, hypertension, vomiting, myalgia, backache and arthralgia, pruritus, urticaria, rash and dyspnea and hypersensitivity. These are very common to all whatever the patient is allergic to. Rare are anaphylactoid, which are less than 10,000, 1 in 10,000. So place, majority of Indian patients with anemia have a weight between 35 to 70 kgs and hemoglobin around 10 or maybe less than 10. To calculate iron requirement by weight and hemoglobin chart, 1500 milligrams and 750 milligrams of 2 doses a week apart can be given. It offers flexibility to doctor. Doctor can choose 500, 3 visits or maybe 2 visits, giving 750 each or 1000 or 500. In many patients who are non-affording for 1000 FCM 500 definitely, or FCM 500 whatever, 750 500 whatever the patient takes, at least give that much, so that you have to counsel the patient. So the place in therapy is again the same chart coming again and again. So the clinical evidence, these are few studies, and the best part is they have come from India, few of them. So comparative efficacy and safety of intravenous FCM and iron sucrose for iron deficiency. No serious adverse events were reported by Shin et al. In Medicine, reported in 2021. And this one is from India. This is comparison of FCM and iron sucrose for iron deficiency, anemia and pregnancy. Our own Dr. Alka Kriplani did it, and the conclusion was treatment with FCM resulted in rapid replenishment of iron stores in pregnant women with significantly high hemoglobin rise over a 12-week period. Convenient dosing with lesser number of total doses to complete the treatment will lead to better compliance in a community setting. These are other studies, and all the key findings is the same, that the mean hemoglobin rise has been shown to be significantly greater in FCM group and versus all others, which is standard care is oral group. So 2 doses of FCM infusion safe and superior to oral iron, and FCM administered as 2 infusions of 750 given a week apart are safe and effective, should be considered a treatment option for ITA. Another study again reporting the same. It's come up with the same results, that significantly greater increase in hemoglobin and iron indices occurred in FCM versus standard medical care. So these are the 2 groups, and the conclusion is again the same. FCM is safe and well tolerated. Another global evidence of FCM use in pregnancy. Current evidence highlighted data of FCM usage in 5,000 pregnant women with maximum hemoglobin rise of 5.5 grams per deciliter and ferritin of 180 micrograms per liter. So this is another efficacy. This is again an Indian study from South India by A. Sharmila, efficacy and safety of FCM in management of iron deficiency anemia, a multi-center real-world study from India, and the results were again the same. Adverse effects were seen only in 7.6% of the patients. Mild adverse events like nausea, headache, diarrhea, constipation, and mild allergic reactions were observed. Hemoglobin rise was really good demonstrable. In severe anemia, it was 3.3 grams per deciliter. In moderate, it was 2.5. This is seen at 4 weeks. The red bar represents after 4 weeks. And in mild anemia, it was 1.8. Similarly, ferritin levels. This is another Indian study from Dr. Prakash Trivedi and team, FCM in management of iron deficiency anemia in pregnancy. And again, the results are nearly the same with improvement in hemoglobin shown to be all across anemia ranges from mild to moderate and severe. So, single large dose administration of FCM leads to rapid rise in hemoglobin in moderate to severe anemia during pregnancy in real life scenarios. So these are the insights we have got from large Indian real seen in just 20 days. So all the vital parameters were well within normal limits over the monitoring period of 45 minutes, and none of the patient displayed any signs and symptoms of acute hypersensitivity. So these are not the neonatal outcomes. Yes, we are looking at the neonatal outcomes also. No adverse effects in terms of perinatal and neonatal outcomes were observed in newborns of women who received FCM during pregnancy. Data of 162 newborns born to mothers who had received FCM was analyzed according to gestational age at delivery, mean birth weight, Apgar score, stillbirth, perinatal and neonatal mortality and requirements of hospitalization, and drop in each and every parameter was seen. So this is what neonatal outcomes week of pregnancy at delivery were not adversely affected due to FCM, rather they were improved because anemia has improved. So we are looking at the drug causing prematurity or not. The drug does not cause. So management of IDA in postnatal period is also very vital because the mother is busy with handling the baby. So that is the time at discharge if the patient is there and she is anemic, and we can offer her a higher dose of FCM before discharge. So in postpartum anemic patients, parenteral iron ferric FCM may be preferred alternative over oral iron for ensuring compliance and faster response. Has an advantage as a bolus dose in the postpartum period for correction of anemia and restoration of the stores. And the summary of key recommendations, that was a FOXY GCPCR, and this is from UK guidelines, that use of IV and iron and postpartum should be considered in women who are previously intolerant of or do not respond to oral iron therapy, where the severity of symptoms of anemia requires prompt management. So supplementation, these are the dosage. That's what I was saying. The Ministry of India has been, Government of India has been looking after from the children 0 to 5 years of age 20 milligram of elemental iron and 100 micrograms of folic acid given per ml of liquid formulation, minimum 100 days in a year. To 6 to 10, 30 milligram of iron and 250 milligram of folic acid, again 100 days in a year, and appropriately we deworm these children. Adolescents are dewormed twice a year, and they can be given a weekly dose of 100 milligrams of elemental iron and 500 micrograms of folic acid. And pregnant and lactating women, they get daily. They do not get weekly. They get daily 100 milligrams of elemental iron and 500 micrograms of folic acid. These tablets are colored differently, although the dose is the same. For the girls it is pink, for the boys it is blue, and for the pregnant women it is red in color. So blood transfusion versus parenteral, we know we are trying to avoid blood transfusion at any cost. The 10 commandments of transfusion practice in medicine state that transfusion should only be used when benefits outweigh the risk. Signs of shock or acute hemorrhage with signs of hemodynamic instability, where we are really boxed into a corner, we don't have anything else. And severe anemia less than 7 grams with symptoms of hemodynamic alterations. During ANC, a trial of FCM is to be given before blood transfusion in women coming with severe anemia. Studies from India identify that PPH is the major indication for blood transfusion in obstetric patients. IV iron such as FCM can be an alternative, especially in women at high risk of transfusion related reactions. It's not only the reactions, it's the infections also we are scared of. So the safety and efficacy of IV iron in reducing requirement of allogenic blood transfusion, an analysis was done and it was seen that intravenous iron was associated with increase in hemoglobin concentration and a reduced risk of requirement for RBC transfusion, and IV iron therapy is effective in increasing hemoglobin concentration and reducing the risk of allogenic red blood cell transfusion. So this is godsend for all of us. So in conclusion, FCM is an ideal parenteral iron, requires no test dose, low risk of hypersensitivity or anaphylactic reactions. FCM dose are calculated according to the body weight and hemoglobin deficit. Most Indian patients are between 35 to 70 with an average hemoglobin of nearly 10 or less than 10. These patients will require a dose of approximately 1500 milligrams, or lower dose can be given. We can again divide 750 weekly or 1500. Significant increase in hemoglobin and blood indices was seen in various trials with FCM 750 milligram compared to other treatments options of IDA, and FCM 750 offers the flexibility for the doctors to choose various parenteral preparations for treatment of IDA. Thank you.